Okay, so the Neuro Exam. We'll talk about a couple of things here, but basically, you're trying to find in your assessment here. Those sorts of things are going to be guided primarily by the information you actually get from the patient history, and then from any sort of exam you've already run, think or fast exam, that sort of thing. Now, it's not always practical, or even the majority of the time practical, to actually give a detailed exam on every single one of your patients. It's more like just giving you a certain set of tools for specific situations that you can use. So I don't expect you to actually know all this, but if you see these sorts of things in your patients, so you know that they're actually having a problem, you should actually give a focus exam, say maybe, just on the nerves that run from the eye on your patient that has difficulty seeing or double vision, that sort of thing. You should have a focus exam on those. And it's going to be guided by your clinical judgment and what they actually tell you on the history gathering section and their chief complaint. So mental status and cognition here. The comprehensive mental status exam has several parts to it, but it should be noted things like the patient's appearance, their level of consciousness, and then mood and affect. They can sometimes get mad at you about asking these questions, but you can kind of reassure the patient by saying first, these are questions we ask everybody, or they're a little silly. You probably heard people say that when they ask those ANO4 questions. But the patient's dress and, are they well kempt? Is their clothing dirty? Is their house dirty? Those sorts of things can help you kind of understand if there's going to be something underlying psychologically wrong with them. Maybe they have schizophrenia or ODD, that sort of thing. Now, on level of consciousness, you've heard some of these terms probably before, but medically, if you say a patient is actually lethargic, that means drowsy but easily aroused, which means they come totally back with it once you actually arouse them. Now, in a tunnel patient, it means basically they're drowsy and have reduced level of consciousness, but it's hard to wake them up. It takes more to actually wake them up. Now, a stuporous patient, that's going to be someone that's unconscious and they can't ever be fully aroused back to ANO4 status, that sort of thing. Think of someone that maybe has like a motor function of 4 on your GCS score. Now, a comatose patient, think of those as your GCS 3. They're going to have no purposeful response even to your painful stimuli. Now, the patient's mood actually refers to a persistent emotional state. It may be over a couple days or a week, something like that, whereas an affect is more immediate. Affect is mainly what we deal with in the ambulance because we're not with them so much, but mood can refer to things like depression, where they have reduced energy, poor appetite, they sleep a lot. Anhedonia there, it means that they no longer take joy in the things that they used to like. And then, of course, suicidal ideation. Now, mania is just, you need to note for people that are kind of bipolar, if they have a persistently elevated mood, they're in their manic state. And people with bipolar that have had it for a while, they know what you're talking about. They can kind of explain that to you. So the cranial nerve exam, I don't expect you to ever actually do a complete cranial nerve exam on somebody. So you can see there that, if they obviously have a CVA or some sort of other neuro problem, you're not going to have to do this complete cranial nerve exam, but it's kind of helpful for your focus exam if they have particular problems, maybe seeing, that sort of thing. It's actually very helpful there. And then you can evaluate people that, you're unsure if they're having a CVA or not. Is this Bell's palsy? Is this, a stroke? That sort of thing. So there are 12 pairs, and most of them connect directly to the brain and brain stem. Some of them don't. The spinal accessory nerve, the 11th cranial nerve doesn't. It's kind of more higher up on the spinal cord, not the brain, but they're still called cranial nerves. You can see in the middle there's actually a rhyme so you can know it if you ever had to actually memorize it. You don't, though. I'm just going to give you a couple of tests that you can give for a focus exam. All right, so the first one is the olfactory, is your sense of smell. We generally don't test this unless there's a specific complaint from the patient about not being able to smell. But just an easy test is to, open up an alcohol wipe or one of those ammonia tablets and see if they can actually smell that. Your second cranial nerve is your optic nerve. It's the one that actually lets you see. So what you basically do is have the patient cover one of their eyes with their hand. And then in several areas of the lung field, while they're looking, straight ahead, you can test their peripheral vision. Just hold up 1, 2, or 5 fingers, basically in front of them and to the side a couple places, to the upper left, upper right, lower left, lower right of the visual field while they're looking straight ahead, and see if they can actually tell you how many fingers you're holding up. There's a couple of actually glossary terms here I don't expect you to know, but you're going to see some of these things as you go along, like bitemporal hemianopia. That's basically a lesion right at the optic chiasm, and I'll show you a picture of this. It's where the left and right eye optic nerve actually come together, kind of form an X. You maybe have seen a picture. Now this quadranopia. Those lesions affect basically 1/4 of the visual field. Think upper right or upper left, that sort of thing. And it's a lesion of the optic radiations, and I'll show you that. It's going to say number 2 there on the picture I'll show you. Now, homonymous hemianopia. This is actually a lot more common, and I'll show you this here in a second. It's basically a contralateral lesion of the optic tract, and I'll show you a picture of this. It's basically if the left side of their left eye wasn't able to see, and then the left side of their right eye wasn't able to see, so they can't see peripheral out of their left eye, and they can't see basically where they're straight ahead on the left side where their nose is on their right eye. Both of those fields are kind of in the same sort of nerve pathway is what it's talking about here. And that's actually quite common for people that have optic nerve problems or maybe have been assaulted, that sort of thing. And those are the kind of people that you would check this on. So you can see here what I was talking about. So basically, you can have where you can't see on both sides of the visual field. You're on number 2. Like I said, the peripheral side of your left eye and then the medial side here of your right eye will also be blind. And those are under number 2. So like I said, it's going to be down here on these tracks where these things cross and things. This number 1 is going to be a problem with the optic chiasm where it was that bitemporal. And that's going to be the peripheral side of both eyes. And basically what the problem is there's bleeding or there's some sort of lesion actually here at 1, or if it's, they complain about things like number 2 where they can't see after you've done your exam. That's going to be farther along here on this optic track. Okay, so the 3rd, 4th, and 6th nerves are actually tested together, and you've seen this before. The oculomotor, that's the one that actually we test with if their pupils actually constrict with the light. And then there's trochlear and then abducens. All of these actually control the movement of the eye muscles that actually control the movement. So all these are tested together. So normally patients' eyes should move together, if they shouldn't be too cross-eyed or if one eye's looking left, the other's right, that sort of thing. That's called conjugate gaze. That's going to be normal. Now, if there's a lesion that cuts off one of the tracts of the 3rd cranial nerve, the oculomotor, basically it'll result in ptosis, and we've gone over that in that Bell's palsy lecture. And the eye is going to abduct. It's going to point away, and it's going to go down. So this is called down and out. And they're going to have pupil dilation because anytime you actually kind of cut off the 3rd cranial nerve, which controls constriction of the pupil, your pupil is going to dilate. After it's a problem with the 4th cranial nerve, what's going to happen is the patient's actually going to kind of tilt their head and turn away from the affected eye because they can't see. But with the 6th, it's actually going to cause their eyes to cross here. Because it abducts, it moves it away. If you're looking to the left, it moves your left eye to the lateral portion. And you basically can't abduct the affected eye. In order to test this one, what you do is you hold up an object, basically a pen, and have them follow it. And then you're going to make an H in the air with that pen. So you can start upper left and then go lower left. And then come up and go in the middle. And then upper right, lower right. And then right in the middle of that H where they're staring straight ahead, at whatever object you have them looking at. You just move it closer to them to see if they can actually abduct or adduct their eye. Now, the next one you can test is a trigeminal nerve. This is the fifth cranial nerve. There is a condition called trigeminal neuralgia. It's very painful, and it's all over your face here, but it's responsible for sensory information from the skin of the face. So basically, what you can do is just lightly touch and see if they can feel that. If not, something a little harder, maybe like pinch, something like that. It also provides innervation to the muscles for when you chew your food. This is the trigeminal nerve here. You can see that there are three branches here. One goes up to the eye here, one right across the face here, it ends at the nose, and it's one that goes down the mandibular branch, which is basically your jaw, and it can actually help you with some sense of taste here. It's something called the lingual nerve, basically the tongue nerve. The cranial nerve we've gone over before in our Bell's palsy lecture. This is the facial nerve, and there are generally here 5 branches here, which you can see on the right, and this is the one that's affected in Bell's palsy. You basically assess it by having the patient do things like forcibly close their eye and don't let you open it, puff air in the cheeks, wrinkle their forehead. That one especially should be remembered for the Bell's palsy lecture. You've probably seen the doctor maybe on people that might have a CBA doing some of these things to the patient. Now, if there is a peripheral lesion, which basically means, out toward the ends here on whatever branch of the nerve there is. So all this nerve is going to be a peripheral lesion, whereas a CBA, a stroke, is going to be a central lesion because it's right in the brain. But it's peripheral. If it is, it's going to produce eyelid retraction, which is going to be basically where the eyelid droops. All right, that's going to make one of the eyes actually appear larger than the one that's normal on the unaffected side. But the forehead is actually spared in central lesions, like when you're having a stroke, so they can wrinkle their forehead in that, even if they have facial droop. Whereas if they're having Bell's palsy, they can't actually wrinkle their forehead. So that's kind of how you would test that one. All right, so the 8th cranial nerve, this is going to be if someone reports difficulty hearing. It's real easy to test. You'll basically have them look at you, then you'll hold your fingers by their ear and rub them together and see if they can hear that. Now, the 9th and 10th nerves are actually tested together, and probably everyone, if they've ever been to a doctor's office, has had this tested. So you're going to have the patient open their mouth and say, ah, and you're going to look for things like if there's actually any deviation back there, uvula deviation. But the reason we do that, because it's basically the sensory limb of the gag reflex. So the gag reflex is from this 9th and 10th cranial nerves. It also helps with your taste. Now, the spinal accessory nerve is the thing that actually helps you shrug your shoulders. So what you would actually check if someone reports weakness just in their upper body, you do things like hold your hands over their shoulders and have them shrug their shoulders, or have them press against your hand when it's on the jaw to see if they can actually do it against some light resistance and see if that hurts or what they kind of report. So the 12th cranial nerve, the hypoglossal nerve, it's basically for the tongue. If you ever had a CVA patient come in and the doctors had them stick out their tongue to see if it actually stays midline, because in things like strokes, it can actually go to the left or the right depending on where the stroke is. So that's actually kind of helpful to see if someone's having a stroke, just kind of have them stick out their tongue. Now, the motor exam on the neuro exam here, it's several things that you know. Maybe you're not thinking you actually test this, but it's going to be, muscle bulk, strength, dexterity. If you do a fast exam, this is basically what you're doing. You're having them squeeze your hands, or you're having them smile, that sort of thing. There's going to be certain things that you're not going to think of. For instance, if the muscles of the calf are hypertrophic, they're bigger than normal, and we've talked about this, that kids should be tested for Duchenne's muscular dystrophy, especially if they're male. Now, muscle tone is actually basically resistant to passive movement. So, if you can think about when we actually have them push down on our hands on the fact exam with their feet, that's going to be a muscle tone kind of test as well as strength. But muscle power or strength is kind of how much force the muscle can generate. Is that equal on both sides? And then check for pronator drift, basically arm drift, where you have them close their eyes, hold out their hands. Does one drop or not? Okay, sensory testing. We don't do this a whole lot unless the patient actually has what we think may be a spine or C-spine problem. This is going to be where they report numbness or tingling or they can't move. Maybe they can't move, but they can feel. That's going to be a different kind of problem. It basically consists of several things here: light touch, pain and temperature, and then vibration and proprioception. So basically light touch, pain and temperature, those are going to be carried on different peripheral nerves. Like their shape is going to be different. And then things like vibration and proprioception. Proprioception refers to actually knowing where your body is in its space. So think about if you close your eyes, can you actually touch your nose without looking at it with your finger, that sort of thing. So the vibratory sensation and proprioception are actually carried on large fiber nerves, but pain and temperature on small fiber nerves. So you can think of your diabetic patients. They're going to have problems with pain and temperature. They're not going to notice those cuts on their feet or their legs that are getting infected, that sort of thing. The reason is because diabetes actually affects only the small fiber nerves. But those patients actually can usually walk on their own, so they can use proprioception and they can feel vibrations. And this actually is carried on in the spinal cord. So different tracts are going to carry pain and temperature, whereas a whole nother set of tracts is basically going to carry your proprioception and vibration sense. So in order to test actually proprioception, any police officer is going to know how to do that when you do things like walk a straight line, but you use the finger and the nose on standing. So again, you would just have them close their eyes and touch their nose with their finger, and then flexion and extension of the great toe once a spot. Supine patients. What I basically mean by that is you'll have the patient close their eyes and you're going to hold the other toes down, and then you can actually move the great toe either up or down and have the patient tell you which way it moved. It's actually a test for proprioception. So coordination and gait. This kind of thing is why it's important to actually have the patient walk to the cot if they can. So if they have, a lack of coordination or incoordination with intact motor and sensory testing, so they don't report any problems with motor and sensory, the FACT exam was negative. So if they actually have a walking problem, then that means that they're actually probably have a problem with their cerebellum. Now, this cerebellar dysfunction often results in something we call ataxia, which is just a lack of coordination, especially in walking, because your cerebellum actually controls your movements. If you can think of whenever you touched a hot stove and pull your hand back fast, it's kind of spastic movement. It's not very well controlled. And the reason for that is because that movement kind of bypassed the cerebellum and it just traveled down the spinal cord. So your hand is lifted before you even feel the pain. But you may have seen this tested on, possible CBA patients where the doctors had them actually take their heel and glide it across their shin. So that's a very common test. So you don't even have to see them walk 100% of the time. But you can ask them to kind of guide their finger back and forth from your finger. So you'll keep it as kind of a target. You'll put your own finger one place and then make sure it's far enough away that they have to outstretch their arm and extend it totally. So you can see if there's actually a bit of movement or tremors that there shouldn't be whenever they do that. And you can do that several times. You also have them basically, they can hold out their palm and then put their other hand in it and move it back and forth, kind of up and down with that a couple times. And that helps you with this coordination. If they have difficulty with that sort of thing, they might have a same side cerebellar dysfunction. So if they can't do that too rapidly on their right, it would mean that it's going to be on the right side of their cerebellum. Now, if it's kind of a midline problem with their cerebellum, they might have truckle ataxia, which kind of means they have difficulty walking. You can think of this as patients that kind of look drunk when they're walking, if they haven't had alcohol. And this could be something that can point you to more of like a cerebellar stroke. Now, there are other gait abnormalities. There's one called gait spasticity, and they kind of walk like Frankenstein's monster, or hemiparetic gait, which basically means they're kind of having this drop foot problem, and they kind of list to one side or the other. And then people that have Parkinson's disease, if you've ever been around them, they have kind of the shuffle when they walk because they have poor coordination.